Right, well, welcome back. This lecture is going to get into some of the sort of technical issues about how we model the time spent in different health states. But the main thrust is not to teach you the sort of technical aspects, but rather to give you a sense of how sophisticated the analysis is becoming. What at first sight seems a straightforward question, how much time will the patient be likely to spend in different health states in the future, becomes increasingly complex as we look more closely. Now, just to remind you, why are we interested in this? Well, it's all to do with the idea that changing survival of patients is very important. Helping people live longer is important. And I don't think anybody will disagree with that. We might have different views about how important it is if the patient's 95 with comorbidities and things like that. But in general, extending life, lengthening life is thought to be a good thing. I'm very proud of this photograph. It's a graveyard beside the main hospital in Bergen in Norway. And I particularly like the way the lines go in straight lines. I feel it's almost professional, but it was just an iPhone 4S, but still. But that's hence the symbol. The graveyard is obviously death being commemorated, but the thing we're really interested here is survival. Okay. Now, why is it so important? Well, I said this morning, I'll repeat it now. The time that patients spend in different health states will affect the costs of looking after them. The time that patients spend in different health states will influence how many quality-adjusted life years are being generated. So it's affecting the costs and the benefits. Now, to start this off, I've got a sort of motivating example to highlight its importance. And it's a drug called azacitidine for a condition called myelodysplastic syndromes. Now, those of you who are clinically trained, that will mean a lot to you. The rest of us, essentially in this condition, the patient is not forming blood cells properly. And if you stop forming blood cells properly, if they're misshapen, etc., they won't function so well and you have some bad health consequences. That's all we need to know about the clinical aspect of the problem. Throughout, I'll be emphasizing, after the example, hazard rates. And the main hazard we're interested in usually is the hazard of dying. And I'm going to say quite a bit about treatment switching at the end. Okay, so myelodysplastic syndromes, or MDS, essentially your blood cells are reducing. You're not producing new healthy blood cells. And in due course, you're going to have bone marrow failure. As a consequence, you're at increased risk of infection, increased risk of bleeding, increased risk of anemia. And also, there's an increased risk of transformation to something called AML, acute myeloid leukemia. So it's a pretty nasty condition. It's not very common. The UK incidence is, and I'd imagine Japan is probably similar. UK incidence 3.6 per 100,000. Average age at diagnosis 70 to 75. And quite often these patients are fairly frail when they're diagnosed. So azacitidine, a fairly new drug, came on the market just a few years ago, has a market authorization for patients who are not eligible for stem cell transplantation and who have this particular condition. So the technical bit doesn't really matter very much. Essentially, it's just saying your fairly severe case, those who are indicated as suitable patients for this condition or this treatment.